Well, this is probably good news. Governor Abbott and the Texas Health and Human Services Commission announced that they've secured $2.6 billion in federal funding to support hospitals that provide care for people receiving Medicaid. That's
Good.
that's 1.07 billion more than they got last year.
Wow.
Mm.
Wow.
So that could be good.
Yep.
And it just filters down to the right people, us being one of the right.
That's always the rub, isn't it? How it gets filtered down.
It is always the rub.
So, Brad, are we ready to start recording?
I'm ready anytime you guys are. So.
Oh yeah, we're ready to go.
Okay. Yes. Okay, Dr. Emmer, whenever you're ready.
Well, it's my pleasure today to have the opportunity to introduce to you today's speaker. For the past few months, we have had quite a bit of focus on the novel coronavirus, and it's been so much at the focal point of what we do every day. It's kind of hard to think about much of anything else. As a researcher and healthcare providers work harder to better understand COVID-19, people and in institutions like UTMB are dealing with a very broad palette of looking at opportunity to go upstream as far as possible to discover how we can better diagnose and then treat this disorder. A person who's on the forefront of that, we don't have to look very far for expertise at UTMB because Phil Keiser is no stranger to novel or unusual emerging infections. Phil was just fresh out of his residency and fellowship program when the human immunodeficiency virus appeared on the scene in wide-scale format up in Baltimore. And he began his work there later on down in Dallas, becoming somewhat of a national celebrity in his outspoken and forthright approach to advocating for individuals who had HIV viral infections. He brought credibility and incredible knowledge to that arena through his clinical trial studies and through his very human-focused work with that population. We need to identify HIV positive people and rapidly link them to treatment at that time and not just manage the infection itself, but link to treatment that's holistic. We need to care for all sorts of needs. Being instrumental in this effort, UTMB initiated an HIV routine screening program in the emergency department on our Galveston campus, and we're now expanding our efforts on the League City campus. I want to thank Isabel Clark and everyone else from the Department of State Health Services who supported us in this collaboration, that doctors Hani Sarak and Dr. Keiser have gotten off the ground here at UTMB. You know, when you have a new procedure or a new pathway for a diagnosis like this, sometimes people are very reticent to jump aboard. Sadly, I'll emphasize that. But I remember quite well the enthusiasm that Dr. Keiser brought to me just by telling me the amount of money spent on one case that had appeared in the UTMB emergency room 5 times without an HIV test being ordered, and the amount of money that all those visits cost, and fortunately the wear and tear on an individual's life who was failed to be diagnosed with repeated infection visits. And when this program went into place, that individual appeared yet another time and was caught by a diagnostic test that could have avoided all those other trips to the emergency room. So it's that kind of thinking about diagnosis early on and treatment introduction that we're all about in medicine and making the world a better place in which to live. So, and none other than Philip is responsible for those kinds of programs. He is the director also of the Ryan White Clinic in Galveston and the lead physician, the Regional AIDS Education and Training Center. Dr. Keiser is well informed, well versed in this topic. So at this time, I'm really, really happy to introduce not only one of my best friends, but also probably the most learned man in the world on the subject of HIV infections and treatment and care. Philip?
Oh, thank you very much for those kind words, Ben. So what I'm going to do, let me get my screen up and share it. And there we go. All right. So can you see my screen and my slides? Annie, can you see them?
Yes, everything looks good.
Okay.
Yes.
All right. So what we're going to do today is we're going to talk a little bit about where we've come in terms of HIV testing and what the goals are in terms of our national goals for HIV. And quite frankly, we haven't talked about them very much since COVID started. And then talk about how COVID has both interrupted it, but also I think is providing us with opportunities to expand our HIV testing. So without any further ado, let me get this up and
Perfect.
going. All right. Remember these days, the good old days, peace, love, and understanding. You know, we kind of look at it and smile, and sort of in my quarantine mode, I think, oh, wouldn't that be nice? And then my local health authority hat goes on, and I go, oh my God, this is what Galveston's going to look like tomorrow. Fortunately, I don't think so. But this is in many ways the roots of the spread of the HIV epidemic, is with changing sexual mores and the sexual revolution, both in heterosexuals and gay men, that occurred in the 1960s and 1970s. And then HIV wormed its way into our society, and we started seeing increased numbers of people living with HIV. So if you look at this graph right here, this shows you the number of people who actually had AIDS or diagnosed with AIDS, and this shows you the numbers of deaths. And then in 1995, boom, we see this huge drop between 1995 and 1996. And that's what was the introduction of HIV protease inhibitors, that we could actually prolong life and stop the progression of HIV infection. It was a very exciting time, some ways very reminiscent of what we're going through now. And that, we had a lot of people who were adversely affected by this virus, and we were getting new diagnostic methodologies. We were getting new treatments. The initial ones didn't work very well, and then suddenly it all came together. And we started to see a large decrease in the numbers of deaths. And with that, we started to see the prevalence of people with HIV increase. That makes sense, right? Because people aren't dying in their 20s or 30s, and they're living normal lifespans. But look at this in terms of the numbers of deaths. It dropped dramatically in 1998, and it's just slowly been going down. And there are still a significant number of people in America who die from AIDS every year. And so we need to get control over this. We have good therapies that can extend people's lives, but the problem is not everybody's getting tested. They don't know their status. They're not getting into care, and they're not benefiting from the therapy. In addition, if we want to prevent HIV, we've got to look at both sides of the coins. We have to look at those people that are positive and those people that are negative, and look at that interaction and try and interrupt the transmission of HIV. We're actually living in a hot zone for HIV. This shows you the prevalence of HIV on a per capita basis, and you can see it's concentrated mainly in the South. In the North, it's Texas, it's New York and Maryland, but Texas, Louisiana, Florida, Georgia, South Carolina are real hotbeds of HIV transmission and high caseloads of HIV. This is in Texas, and look at what we see here. The brown are the highest rates, And here we are in Galveston County, and we have as high rates as they have in Harris County and in Houston. And so even though we're a small county with only about 340,000 people, the proportion of people who have HIV in our county is the same as Houston, which is considered one of the national hotspots. This is probably the first and last time you will see something like this happening. So this is President Trump's State of the Union address. And what you will see is that on both sides of the aisle and in the gallery, people are standing up and applauding the president. And the question is, what was he announcing? And basically, he was announcing ending the HIV epidemic initiative. And the idea was to put money and resources and change strategies in terms of the way that we treat HIV in the United States so that we can drive down the numbers of infections so that we get to the point where when we have a case of HIV, we can do case finding and then try and isolate those individuals, get them on therapy, and prevent furthering the chain of transmission. So the goals were a 70% reduction in new cases in 5 years and a 90% reduction of new HIV cases in 10 years. If we look at the rate of new infections that are occurring and look at what the models are in terms of how many cases we'll have globally, this is what's projected globally. This is where we are right now. And then with rolling out of the PEPFAR project, where people are being treated with HIV around the world. And here we are now in 2020. If we would do nothing, this is where the total number of HIV cases would be. But if we get really ambitious and treat everyone aggressively, get as many people on HIV therapy as possible, and also take prevention methods and put them into practice, we could actually get down to a very, very low rate of HIV infection around the world. There are 4 pillars of ending the epidemic. The first one is HIV testing. We'll talk more about that than anything. Rapid treatment, prevention of HIV, and then lastly, a response to outbreaks. So one of the key things in trying to prevent HIV is understanding what is called the Pareto principle, the 80-20 rule. And the 80-20 rule is that over 80% of the HIV infections are transmitted by 20% of the people. And what we know about that is we know that most of those people who are transmitting do not know their status, and most of those people are relatively early on in the infection. So if we could identify who these people are and get them on therapy, then we can potentially reduce the rates of HIV. With the president's plan, they are going to concentrate in phase 1. They were going to concentrate on the cities where they have the highest rates of HIV infection, which account for 50% of new diagnoses. So in Texas, you see it here, that's Houston, Dallas, Fort Worth, Austin, and San Antonio. They also are looking at new states where HIV infection, where rural cases accounted for more than 50% of their cases. And so with that, they brought in these states of Oklahoma, Arkansas. So we're down here in Galveston, and remember, our numbers are low, but our rates are very high. And in fact, our numbers are as high as Oklahoma's. You know, we're one of those places that with this initial initiative did not get included. However, we were able to get some grant money to do things like doing diagnostics in the ER, and so help to set up a PET program. So the key to this is people knowing their status and knowing whether they're HIV infected or not. The CDC currently recommends that every person between the age of 13 and 65 have at least one HIV test in their lifetime. So that means we should all be tested, and we should all know what our HIV status is. And then if you have reason to test again and test on a regular basis because you've changed sexual partners or had other exposures, then those people should be tested on a regular basis. So think about that, whether you've had your HIV test. If you haven't, we can very discreetly arrange one for you, and there are places that will even do anonymous HIV testing. So we've already talked about this between 13 and 65. Our target areas are actually looking at hospitals, emergency rooms, and clinics. Why looking at those places? Well, turns out many people still get diagnosed with HIV when they have their first opportunistic infection, and they end up in hospitals. The second place that we really want to focus on is in emergency rooms, because the rate of positivity in just the average emergency room population is about 4 times higher than the general population. Why is that? Well, it's because people with HIV, they're starting to get sick. They don't know they have HIV. They go to the hospital. They go to the emergency room. They sometimes show up in the emergency room multiple times. And when that happens, you can see that you get this confluence of folks in the emergency room. So by doing routine testing in the emergency room, you can potentially snag a lot of people, identify them, and get them into care before they get so sick that they need to get in the hospitals. And then lastly, trying to do it in clinics so it becomes part of routine care. You would be amazed. This recommendation has been out for over 10 years. Yet think, when was the last time you went to your doctor? And when was the last time they asked, would you like an HIV test? Why do I need an HIV test? Oh, it's recommended. Have you ever had that conversation? All right. And that's the problem, is we're trying to change cultures and get people more aware and get doctors more aware of offering it. There's still a big stigma around offering people HIV testing. There's still that fear. If you say to someone, oh, we'd like to get an HIV test on you, that they'll go, why? What do you think of me? What do you think I've been doing? In my experience is that 99% of the time when we say to someone, we'd like to get an HIV test to make sure you don't have it, they go, oh, okay, that would be good. And in the rare time when people are very, very defensive, I don't know if I want you to test me, there's usually a reason for that there's something going on that they don't want to talk to you about. One of the ways that when we talk about prevention, testing and knowing people's status is a very important thing. But the other thing is preventing transmission. This is the traditional way that we have tried to get people to prevent transmission. And this is with the use of a condom. I love this picture because it really brings out all of the issues of condom use. You can see the person holding the condom. It looks like a woman's hand to me, but we really don't know whether it's a woman or a man. And that's in clear focus. And you can see the guy over there, and he's distant, he's out of focus, and he's going, do I really want to do this? And so we've had to change strategies because, quite frankly, condom use, if you use it, it works. But unfortunately, not enough people are using condoms. So now we have a medication called Truvada. It was initially developed as a drug to treat HIV infection. But what we found is that if you give it to individuals that are at risk for HIV, that is, that they're engaging in high-risk sex or they have partners that they don't know their status with, it can actually prevent the transmission of HIV. How good is it? The answer is it's really good. This is a study called the IPER-GAY study. This is one of my favorite studies with looking at PrEP, as we call it, or using Truvada to prevent HIV infection. And so this is a group of young gay men, primarily done in Great Britain, and it was given on an intermittent basis. So today's Thursday. So if it's Thursday and I decide, hey, I want to go out at the 4th of July weekend and I'm going to go have a good time, I can go to my clinic and they give me some tenofovir. And in this case, they gave them tenofovir or placebo. And when they gave people the drug, they would take it for 4 days or 3 days, and then they'd look at how many of them had HIV infection. You can see these are the number of HIV cases in people that got placebo. You can see there were only 2 cases of people that got HIV infection when they took tenofovir. There's been a lot of concern about the effectiveness of this. There's even a more recent study that was done that looked at discordant couples where one couple had, one member of the couple had HIV and the other did not. And in a large placebo controlled trial, they found that there were 14 cases of HIV transmission in people that were taking tenofovir. Okay, but then what they found was that they were not, that they were, the people, those 14 that got infected, they actually were having sex with other people besides their partner who were taking the drug. So in other words, there was basically no attributable transmissions in couples that were being faithful to each other and taking this medication. So it works very well. It's now part of our national treatment strategy. We now have a PrEP clinic in Galveston County at the health department, and with Coastal Health and Wellness and in collaboration with AIDS Coalition of Coastal Texas, that anybody who needs it can get it regardless of ability to pay. And so we encourage people, if they are having multiple sexual partners or just in a situation where they feel that they're at risk, to go to that clinic and we can provide therapy for them. One of the core parts of trying to get HIV to decreasing HIV transmission is this idea of U equals U. Undetectable equals untransmittable. So in other words, if you are HIV positive and you take your HIV medicine and you have no virus in your blood, you're not going to transmit it to anyone else. It took a long time for the scientific and public health community to come to believe this. There has been data for quite a while that just was growing and growing, and finally some really good studies were done. And now I think everyone truly believes that if you have an undetectable viral load, then you're not going to transmit it to everyone. So what that means is that if we can find those people, that 20% that's out there transmitting HIV, and we can get them treatment within 7 to 14 days of their HIV diagnosis. We can get them their physician visit, we get their labs drawn, we give them a prescription for HIV medication. We can reduce their viral load very rapidly, and then we can help prevent further transmission. Part of the reason we can do this is because of integrase inhibitors. This is a drug called dolutegravir, which is an integrase inhibitor, and there are several others that are out there as well. But one of the unique characteristics of this new class of drugs, which we've had for about 5-6 years now, is that they drive viral load down very rapidly. So look at this, at 4 weeks, 80% of the people have an undetectable viral load, compared to a protease inhibitor, more standard therapy, where it takes almost 6 months. So this person could be transmitting HIV during a whole 6-month period of time, whereas it's likely that someone you treat with an integrase inhibitor is within 4 weeks is not going to be transmitting HIV. So if we can identify those people, get them on these drugs, which are, by the way, are very non-toxic and we can give as one pill once a day, we see people do extremely well. They've actually employed this strategy in San Francisco, where back in the earlier part of this century, they simply decided we're going to do everything we can to try and reduce the numbers of infections in San Francisco. And so they started a project called Getting to Zero. And with that, they offered widespread HIV testing, and then those people that test positive, they were referred to Rapid Start to get on their medications very rapidly. Those that are negative, they had a risk assessment done, and if they were considered high risk, they had them put on PrEP. And look at what's happened to their numbers, okay? They started off in 2007 with almost 600 new HIV cases per year, and by 2016, they're at 223. I can tell you in 2018, they're less than 200 a year. So this strategy works. It doesn't work just in San Francisco. They use a similar strategy in New York or San Francisco. In Washington, D.C., they are also employing a similar strategy. So it's very important for us, if we want to get our HIV numbers down, to start improving our testing, get more widespread testing so we can identify people and then get them on therapy as quickly as possible. So we were all set to do that, and we actually started a program last year where we started testing in the emergency room, and then this happened, right? And we all know what this is. This is the COVID map, and if you haven't seen this map, I don't know where you've been, but these are the numbers of cases, and this map's actually kind of old. It's only 114,000 deaths in the United States there, and we're well above that at this point. We've had to deal with this in our county. This shows you the numbers of cases that we've had by week. You know, here we are in March, and we start having a bump in cases. We had some in nursing homes 4 weeks into it, and at this point was the shutdown, and we see the cases go down, 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 down. And by week 10, we had almost no cases. And I was actually telling my wife as the numbers would come out, oh, I'm just hopeful today we have none. Just was one day where we have no cases. But then we started opening up again, and you can see these numbers going back up and going back up dramatically. And I think you've all seen those numbers and those cases rising very high. You know, this week we're actually looking at somewhere around 1,500 cases, which will be a new record high for us as well. We've also seen an increase in numbers of hospitalizations. We have about 90 county residents that are hospitalized. UTMB has over 100 people with COVID in the hospitals. The good news is that there's plenty of ventilators, there's plenty of ICU space. We have remdesivir, we're giving it to our patients, and so our length of stay is getting shorter. So we haven't had to see a real, I don't want to say what the right way to put it, we haven't been overrun in terms of our healthcare system, but a lot of that goes to, I think, a lot of the planning that Dr. Ramers led in terms of preparing for this. Because I can tell you, if we saw this sort of thing back in April, we would have been overrun. And so, you know, you should be proud of everything that the UTMB leadership and staff has done to help prepare for this. This shows the percent positives that we've seen increase. And we've seen those numbers go up, 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 up. And right now we're running somewhere between 12 and 14% positive of people that have COVID. So what that means is as you're walking around, you pass 10 people, you've passed somebody with COVID, okay? And if you've gotten close to them and talked to them and didn't have a mask on, you're putting yourself at risk. So it's very important that people be cognizant of these numbers and take all steps to try and avoid getting COVID. We then look at where these cases are. And this is what we call a heat map. And so it's done at a level of of what's called a census block. So it's less than a zip code. It's a much tighter group, but you can see that we're having coalescing of all the cases right in the main tourist area. And it doesn't take a genius to figure out that people are coming down I-45 and coming to Galveston on the weekends, and they're spreading COVID, and the folks that work in the tourist industry are getting it. They're taking it home to their family members, and they're getting it. We're also seeing it in Texas City and Lamarck, and then spread across League City as well. So it's everywhere, but it is more concentrated in the tourist region. So what are we doing about COVID, and what's that have to do with HIV testing? Well, I'm going to try and draw some lines and parallels and see some ways that these things can work together. We have a bunch of tests for COVID. The diagnostic test we use is called a PCR test. We have a variety of tests that we employ here at UTMB. 3 of them are, in fact, made by commercial labs. One of them was actually developed here at UTMB by the Galveston National Lab. What you'll see is that there's a different sensitivity and specificity for each one of them. We tend to treat these as positive as positive, but we know we're missing some folks, depending on what test we use. And, you know, some of them, sometimes we may get some false positives, but I think that's probably very unlikely. To get this test, you actually have to have a swab placed inside your nose, hopefully very gently, and all the way into the back of the pharynx, and let it sit there for 10 seconds. I've had it done. It's a little uncomfortable. My father-in-law complained for weeks that they had permanently damaged his brain. And my mother-in-law said, oh, it was kind of fun. So, you know, everybody has a little different perception of the invasiveness of these types of tests. But they really are the mainstay of what we're doing in terms of trying to diagnose COVID infection. There has been a big push, which we have implemented here in doing testing, which is measuring antibodies. In terms of diagnosing acute infection, it's not as useful, very similar to HIV, right? You know, you can have it takes about 2 weeks before an antibody test becomes positive. The same thing is true with a COVID test. But antibodies tell us whether people have been exposed to the virus, had the virus in the past. You can still be acutely ill and have antibodies. And so what we're recommending is if you get an antibody test and it's positive, that you get the swab and the PCR test. But there are 2 ways you can have it done. You can either have a blood test, or you can have what's called a lateral flow test. And I'm sorry, guys, I keep wiggling the mouse when I shouldn't. And that's where it's a finger prick, and you put a little bit of buffer onto where the blood, and it goes up, and you get antibodies detected, and you get a control, and this would tell you that the control is working, and that someone has antibodies to COVID, and you say, well, you've had COVID, okay? One of the problems with antibody tests is that if there's a very low prevalence, you tend to have false positive tests. And so we are very cognizant of that, and we're not recommending it for acute therapy. I mean, for acute diagnosis. So if you have symptoms, we're recommending that you get the swab. But we also recognize that there are going to be some people that don't want to have the swab test, and this is a way that we can identify people. And we will, at a rate of 5% of a false positivity, these tests could be very wrong. But what we've seen is that as our numbers have increased, we're well past that. So right now we're in a situation where if you have a positive antibody test for COVID, it's probably you had COVID, okay? So we're not looking at a low prevalence scenario. So anybody recognize this? This is a lateral flow test, all right? This is something where you get a pinprick, and you stick it in the well, and then it comes up, can be control right there, which is positive, and that would be the test thing, which is also positive. And what I'd like to argue today is that we have a real opportunity as time goes on to start incorporating testing and screening for other things as people are wanting to get COVID tests and potentially vaccination. So look at this. People are lining up to get COVID tests. They're lining up. They're driving up. They're coming into the emergency rooms in much higher rates than they were before. And sometime, Annie was asking me, is it going to be September? I don't know. I don't know if it's going to be September, October. I don't know if it's going to be next year. At some point, we're going to be doing mass vaccinations. We're going to get people lining up to get vaccines. Imagine now if we can, in some of these areas, start incorporating HIV testing into those areas. We have some experience, which I'm going to tell you about now, actually doing it in our emergency room, and can show you what has happened during the COVID epidemic, which was actually a little bit surprising. So last year, when we were trying to get things started up, we looked at HIV testing at UTMB from January to September. There were 23,000 ER visits. There were 530 known positive. 41 HIV tests were sent from the ER, and 5 of them were positive. All of them had multiple visits. You're going 23,000 and only 41 HIV tests? What's going on there? Well, it turns out that ER docs are very concerned about sending tests and doing diagnostics when somebody's going to walk out the door and they're not going to have contact with them. And you can see the legalities and the potential issues there. And they were really worried about it. In addition, they're also worried about, well, how much time is it going to take? How's this going to get into my workflow? Am I going to have to be calling people back up? And so what we had to do was we had to really kind of address some of the issues with regard to how would something like this work. We went back and we looked at those 5 people, and this is what we found. These are 5 different patients, number of ER visits positive. You can see a total of 29 ER visits before they had an HIV test, and the charges that were accrued, over $340,000. And we're still keeping track of this, and we find that people that are undiagnosed and still having some multiple visits. So this, I think, was a major, not convincer, but piece of evidence that convinced people that it was something that had to be done. And so from September to December, we were able to get set up a system where we said, look, we want to help you. We're going to have good case management. All you got to do is order the test. If the test is positive, our HIV Ryan White nurses will follow up for them. We'll get them all into care, and we'll make sure that they're well taken care of. So there was a little bit of reluctance there, and there was some trust building that had to take place, but we were able to get 357 tests in the ER. We had 9 positives. This actually exceeded the number of people that we expected. We had done education with the ER staff, and really put out some guidelines on these are people you must get HIV tests on because they're at high risk. So we want people to start thinking about it and really working to get more. Then COVID hit in January, right? We started having our first tests in COVID. A lot of us got caught up in the planning for COVID at the end of January. But we actually started doing that with some of the ER staff. And a couple of very interesting things happened. First of all, we stopped bugging them about doing HIV tests. That's the first thing that happened. But the other thing that happened was we actually ended up having a lot of conversations with ER administration and ER staff because of COVID coming in. So now we're in a situation where I think there's good communications and good trust between the two, and look what happened. We had 550 individuals and 22 new positives. So even more than what we had done when we were actually making an effort to get the testing done. So we were able to push the needle forward and get a lot more done with this. Everyone is very happy with the way this has turned out. We're now starting discussions to roll this out to League City, and then we'll go to Clear Lake, and then we'll go to Angleton-Danbury and get this rolled out throughout the, across the system in the ER. We're getting those people into clinic. We're getting those people into on therapy, and I think we're making a big difference, and I think everyone's seeing this as a very positive thing. The other nice thing about COVID, if I may say that, is that the federal government has actually given the Ryan White programs to pay for people's HIV tests. So, and to pay for HIV patients to get COVID tests. So we're seeing that we're now having funding that we're able to add to the infrastructure and help defray some of the costs that both go with HIV testing and with COVID testing. So that's, again, another very positive thing from a programmatic point of view. And we've also started doing a lot of telemedicine visits for our patients, and we're finding that that is something that is being very widely accepted, and we hope to then start rolling that out to PrEP as well, particularly in areas that are not close to the medical center for our patients that live in rural areas and have difficulty getting in. So what can we conclude about this? So first of all, HIV testing in the time of COVID has actually increased. I think part of it's comes out of increased awareness of HIV infection. Many of the providers were concerned about interaction between COVID and HIV. You know, does HIV make COVID worse? Does COVID make HIV worse? So far, I can't say that we've seen that, but those are really good questions to ask. And then most importantly, we have a good case management system to identify these folks and get them in care. So that way, the testing physician can diagnose these infections and then basically hand them off to where they need to go and not worry about it. We need to continue to work on that and expand it. We're going to be expanding things in the emergency room. Once we get past this current surge that we're currently having, I think we need to start thinking about how can we incorporate HIV testing in some of the mass testing that we're doing. You know, people could just be asked, oh, since we're drawing your blood today, do you mind if we get an HIV test as well? And there are ways that we can look into that. Or if we have people lining up for antibody testing or for vaccination, we could very easily have a partner there who is doing finger stick testing for HIV. So I think that in some ways COVID has thrown a monkey wrench in things. We really haven't been paying a lot of attention to it. But on the other hand, people's awareness has increased and the interactions have increased. And we're getting good results, and we're finding people that we would not have found. And I think that as we move toward more the new normal or integrating COVID into our medical care and integrating COVID into our normal way of lives, I think there are opportunities for us, not just with HIV testing, but with other types of screenings to include that because people are coming out in droves for healthcare related to COVID and they may not have done that before. So I think there's a real opportunity to do that. So that's all I have for you today. And with that, I will stop and take any questions or comments.
Dr. Keiser, there are 3 questions in the chat box at the moment. So the first one from Misu, she wondered that it seemed that providing COVID-19 data to public has some effects on stopping the spread. Shall we do the same for HIV, or from your point of view, what other ways to make people understand infectious disease and their role in preventing it?
Yeah, I would say the answer is yeah, a qualified yes. And the reason why I say a qualified yes is one of the big barriers toward HIV is people don't consider themselves susceptible, right? You know, well, I don't do this, I don't do that, I don't do drugs, you know, I'm not sexually promiscuous, therefore I'm not at risk for HIV. And we know that while that may be generally true, that you know, you don't always necessarily know what your partner's doing, and there are things you may not know. So what our strategy is going to be as we move forward is really looking at getting those high risk groups. So the high risk groups that are having the highest rates of infection are African American men who have sex with men. We're seeing African American women who live in rural areas. And what we would like to do is pick those target groups and young gay men and start doing those types of interactions to try and see if we can improve people's understanding and need for HIV testing and need for prevention services. We're having discussions right now with AETC as we're looking at our new budget to see if there are ways that we can bring in social media. You know, like some of these young gay guys, you know, the old days of going to a gay bar and testing people are over, right? Because of Tinder and Grindr and other apps where people can meet up and hook up. And so having a social media campaign, I think, is going to be critically important to getting that targeted population who's at the highest risk in for testing and treatment.
Maria is requesting more information about Ryan Wine paying for COVID testing. Also, she asks if there were any surveys conducted in the emergency room for those individuals testing for HIV.
Okay, so let's do the first one, and then I'm going to ask you to repeat the second one. You know, basically, so anyone who's HIV positive, if they don't have any other way to pay for their primary care, that's covered under the Ryan White program, which is a federally sponsored program. That typically has been a fairly limited scope, meaning that it's focused on getting people HIV care and getting people into care for their HIV. It doesn't, you know, necessarily pay for standard screenings with other things that are not related to HIV. But the federal government did decide to give us all some extra money. I think we have about $60,000 for doing COVID patients who are enrolled in that program. If you're not enrolled in that program and you have healthcare insurance, your healthcare insurance will pay for your COVID testing. Within the county judge has committed funding to provide COVID testing for any county resident who doesn't have the means to pay for it themselves or doesn't have healthcare coverage. So there's no reason why someone should not get COVID testing today, and probably no reason why they shouldn't get HIV testing either.
Her second question about surveys, we conducted in emergency room for those individuals we tested for HIV.
Surveys, is that the question? I'm not sure I understand. Does that mean have we asked them questions, or have we done survey or surveillance testing? I'm not sure I understand.
Yeah.
Anyway, yeah, that's easy to answer, because no, we haven't really surveyed the individuals, and we haven't done surveillance testing in a formal way. We're trying to get as many people as we can. Surprisingly, you know, there are some people who don't want to get testing, but you know, I think we've broken through the main barrier, which is getting ER physicians to recognize that COVID is, I'm sorry, I'm getting my viruses mixed up. People that recognize that, you know, HIV testing is really important.
Very interesting question from Alex, asking about what are your thoughts on increased in-home HIV testing during and after COVID-19?
I think it's fine. You know, the home HIV testing has worked out very well. The real issue is getting them into care. And, you know, I think if someone has the wherewithal to keep doing it, home HIV test, and then get it, get the result, that they should be able to have the wherewithal to refer themselves. The big concerns with home testing was, what happens if they get their diagnosis? Are they going to kill themselves? And the answer to that is no. I mean, we haven't seen that happen. Are people going to get referred to therapy? And sometimes we do see that people have tested themselves and then they get scared and they run away. So
no more questions. I encourage everybody, if there are any questions, just post it immediately. If not, no other questions on the list.
Okay, well, thank you all very much. Thank you all very much. I appreciate it.
Dr. Keiser, thank you very much on behalf of everybody who tuned in to listen. I know this is a really uncertain time and a new normal. All of our schedules have been turned upside down, and I just want to take a moment to express my thanks to you and the entire infectious disease team at UTMB for not only your incredible ability to think and address all the different issues that you have, but to coordinate prevention as a part of your primary aim. That's a great thing that you have found a time and place for that, at the same time offering some of the world's best treatment for people who are suffering from COVID. This is, there are a lot of parallels between COVID and HIV. We can learn a lot of lessons. So thank you for being so well trained and so adept at generalizing these desired behaviors. Thank you.
Oh, thank you, Ben.